ASH 2015 coverage on Orlando, Florida continues. I'm Thomas Baldrick, joined now by Dr. Saunthararajah from the Cleveland Clinic. How did I do on that?
You did pretty good.
All right.
Good, yeah.
All right. So let's talk about the research you're doing for MDS and AML patients. What study are you presenting data for here?
So there are only two drugs FDA approved to treat all subtypes of myelodysplastic syndrome. These two drugs, Decitabine and 5-azacitidine, are also very important for patients with acute myeloid leukemia. They extend survival for patients with acute myeloid leukemia as well. But unfortunately, neither agent by itself is a cure. So almost inevitably, every patient benefiting from these drugs, the disease will eventually relapse. So the big question really as it pertains to these two drugs is, they work great, but why is it that eventually the treatment selects for a subset of the leukemia cell population or the myeloid malignancy population that is able to grow despite the therapy and basically cause the disease to recur? And so we were addressing that question, the question of resistance.
So before we get into what you found, what was your hypothesis going in?
Right. So we had a very simple notion. We know exactly what these drugs are trying to do. They're trying to actually deplete from the cancer cell population a specific epigenetic protein called DNMT1 or DNA methyltransferase 1, DNMT1 for short. So we know what these drugs are trying to do, and since we know what they're trying to do, we can measure that. And so we can modify the question about how is resistance occurring to a logical first step, which is, hey, are the drugs actually doing what they're supposed to be doing, that is depleting DNMT1, or is it that resistance is because the drugs are doing what they're supposed to be doing but the cancer cells don't care? So is it because the drugs are not actually achieving that DNMT1 depletion, or is it because they're achieving it but the cancer cells don't care? So that was the first step. And when we actually tried to answer that question, we found that resistance was with cancer cells that somehow avoided that effect of the drug. So it wasn't that the drug went into the cells and depleted DNMT1 and the cancer cells said, yeah, so what, and just kept on growing. It said that it was that the cancer cells were not even being subject to that effect of the drug. So the drugs, we were giving them to the patient in the expectation that the drugs were going to go in to the cancer cells and remove DNMT1, but that wasn't happening. So DNMT1 was not being removed. So the resistance was because DNMT1 was not being removed altogether.
So now the next question is why?
And so the next question was why. And so there too, fortunately, we actually understand how it is that these drugs get into cancer cells and how they eventually, we know in a step-by-step molecular fashion, this has been worked out over decades, exactly how it is that these drugs deplete DNMT1. So we looked at each one of those steps, and we found that resistance was occurring basically at two levels. One, cancer cells, when they relapse, they were increasing the levels of an enzyme which inactivates the drugs. So there's an enzyme called cytidine deaminase, or CDA, which deaminates decitabine and 5-azacitidine and converts them to their uridine counterparts, which cannot deplete DNMT1. And very, very often, at the time of relapse, the cancer cells had upregulated CDA, thus shifting the dose-response curve to decitabine and 5-azacitidine to the right. You would need a higher concentration in order to achieve what was being done with a lower concentration previously. So that was the first thing these cancer cells were doing. And the second thing they were doing is decitabine and 5-azacitidine are actually what we call prodrugs. They have to be modified before they can actually deplete DNMT1. That modification is by a phosphorylation step. And the enzymes that phosphorylate decitabine and 5-azacitidine, it's two different enzymes. 5-azacitidine has a ribose sugar as its backbone, and decitabine has a deoxyribose sugar as its backbone. And so decitabine is phosphorylated by an enzyme called DCK, and 5-azacitidine is phosphorylated by an enzyme called uridine cytidine kinase 2. And so very interestingly, at the time of relapse, cancer cells being treated with decitabine would suppress DCK, and they would upregulate UCK2. So they need, so step back a little bit, decitabine and 5-azacitidine are cytidine analogs. They're analogs of the C that goes into DNA. Now, in order for a cancer cell to divide, it has to bring in Cs to duplicate its DNA. And so that's what these drugs exploit, is the fact that they need the Cs and then they'll take in the decitabine. But what these resistant cells were doing when they were being exposed to decitabine, instead of using DCK to bring in decitabine, they would shift to UCK2 and they'd bring in the ribose form of the C, and therefore they would avoid the decitabine. And with 5-azacitidine, they do the opposite. So because 5-azacitidine is phosphorylated by UCK2, they would downregulate UCK2 and they'd upregulate DCK. Now the obvious implication, therefore, is that when the cancer cell tries to avoid decitabine by this strategy, it actually increases its vulnerability to 5-azacitidine and vice versa. So when the cancer cell avoids 5-azacitidine by downregulating UCK2 and upregulating DCK, it renders itself more vulnerable to decitabine. And so we tested these principles in mice, and we showed that in fact, when you alternate decitabine and 5-azacitidine, you can actually dramatically extend the response duration to this form of therapy. And remember, I started out by talking about the enzyme that cancer cells upregulate in order to deaminate and destroy decitabine and 5-azacitidine. If we inhibited that enzyme, we could even further dramatically extend survival, all without toxicity.
What do you think this means for patients?
So the good news is that all of this is, these are very actionable findings. These are things that we don't have to wait for theory or a new molecule or a new gene, or we can actually act on this tomorrow, and so we are going to act on it. So we're going to be starting clinical trials with decitabine in combination with an inhibitor of cytidine deaminase, and we're working towards hopefully doing clinical trials where decitabine in combination with the inhibitor of cytidine deaminase will be alternated with 5-azacitidine in combination with an inhibitor of cytidine deaminase. And in that way, we hope to rationally extend the response duration to these drugs.
Exciting news, Dr. Yogan. Keep us posted, would you? Come back.
Thank you much.
Thank you, sir. My pleasure.